guys! So, I'm not a YouTube star, so don't judge. I have had a lot of friends who frequently ask me about this topic I'm going to share with you. So, this started as a school assignment because we post a lot of video discussions. For those of you who don't know, I'm in midwifery school. And now I'm going to share via video with you guys because I think this information should be out there in the world, and I'm passionate about it, obviously. And research, I believe, should be readily available at mama's fingertips in an understandable form instead of locked down in a dungeon library. So you only have, your sole provider's point of view as a frame of reference. Academia should not be the only place where we discuss these things. Mamas are absolutely smart enough to make their own informed decisions based on the evidence. So with that being said, I have a disclaimer. As a labor nurse and soon-to-be midwife, I support all kinds of birth choices, whether it's birthing in a cornfield with the cows, at a birth center, at a hospital, at home, in the McDonald's parking lot, or via C-section. I support mama's choices to birth where and however they want, regardless of my own opinions, whether they be professional or personal. No judgment here. I support you, especially support your decisions and your ability to make your own choices. Okay, stepping off my soapbox now. So, what I want to talk to you about is several recommendations given by ACOG. So, I know, it sounds boring, but just wait. So, ACOG is the American College of Obstetricians and Gynecologists. They are an organization that utilizes research to create guidelines for healthcare practice. So, a lot of hospitals, including some that I've worked in, and organizations use their recommendations to form their policies and procedures, so how they deliver healthcare, essentially. As an example, if you remember a while back, all of the hospitals, or a lot of the hospitals in this area, started taking away the opportunity to birth in a labor tub. So this organization, ACOG, gave a statement about that, and then that's when the hospitals made the decision to get rid of water birth based on that statement. So if you remember that, that's where that came from. So in 2017, ACOG collaborated with the ACNM, which is the American College of Nurse Midwives, and also the Association of Women's Health, Obstetric, and Neonatal Nurses to form a committee opinion, which is committee opinion number 687. It is titled, Approaches to Limit Interventions During Labor and Birth. So, like I said, this is a frequent topic of discussion when people come to me and they're asking, what is the evidence, what is safe, what is recommended? And so I'm going to quickly give you an overview of what ACOG recommended in this recommendation after collaborating with these other groups I mentioned, and also after looking at all of the current evidence we have through research, because as healthcare providers, we always want to provide care that is based on evidence and has been proven, because surely you'll appreciate that, right? You don't want us just doing things because we feel like it, you want it to be evidence-based. So here you go. Basically, all of these recommendations are in the event that mom and baby are both doing well, showing no signs of distress, and also assuming that this is a term, so not a preterm, birth, and there are also no other outlying risk factors present. So these are for healthy, low-risk moms. Obviously, these recommendations would change should the individual patient's needs change based on risk factors. With that being said, this is what they recommended, which, by the way, you may find is different from what is sometimes practiced if you have had a traditional hospital birth previously, or if that's your only impression from TV of hospital birth, whatever your experience with birth is. You may notice that these vary for what is traditionally practiced. And like I said, these recommendations came out in 2017, so just a year ago. So number one, labor management should be individualized, involving intermittent auscultation versus continuous monitoring, and non-pharmacological methods for pain relief. So what that means is intermittent auscultation should be used versus continuous fetal monitoring, where the monitoring is strapped to the woman's belly and it stays on them. Sometimes can restrict movement if that particular organization doesn't have a telemetry type portable monitor so they can walk around. So it's saying using the intermittent oscillation, which uses a little Doppler, which they use at the offices to hear baby's heart rate, check it according to protocol every so often versus having those monitors always strapped on to mom, and also using non-pharmacological, which means non-medication methods of pain relief. So listen, ladies, this doesn't mean no epidurals. That's not what I'm saying here. It's just right now we're talking about early labor, so that there is a long phase of labor before things get active, where your cervix is slowly changing before baby comes. And so the first half of labor can oftentimes be long, and this is kind of what we're talking about here. Okay, number 2, admission to labor and delivery is not necessary in early labor. Encouragement and support, of course, should be provided, but admission is not necessary and does not improve outcomes. So that's interesting. So basically they're saying early labor, that long period I'm talking about, a lot of times that's before, 6 centimeters, that whole long time to get to 6 centimeters or around there. That is early labor, and admission is not necessarily required, and it does not improve outcomes. Number 3, if women are admitted for early labor due to maternal fatigue, whatever the reason may be, techniques such as education, support, oral hydration, so that's opposed to an IV in your arm, positions of comfort should be used, and again, the non-pharmacological pain relief methods such as water immersion, so that's, in a labor tub, soaking in a labor tub, it really helps with contraction pain, or it could also be using a shower to let the warm water run over your belly during contractions. I lost my spot. Water immersion or massage is also beneficial. So again, we're talking about this early labor if mom is admitted during that time period. So notice it doesn't say start Pitocin and get an epidural and do all these things to speed labor up so it goes according to our time plan. It doesn't say any of that. It says in early labor, let's support them and do these things. Okay, that was also my soapbox. Sorry, it comes out every now and then. Number 4, GBS negative mothers. So side note, GBS is a bacteria that is normally found in women's vaginas, and it is not an STD. It's just a normal bacteria that can live there in some people, not everyone. It's similar to the normal flora bacteria that is in your gut that helps digest. It's just a normal flora bacteria that can be in the vagina. Doesn't affect women, can affect baby during birth because it can give them an infection after birth. So, okay, so back up. GBS negative mothers who have rupture of membranes, which means their water has broke on its own, before contractions or labor starts, can wait for a period of time before introducing Pitocin. That's a medication given IV, which augments or starts stronger contractions to move things along. So they're basically saying if your water breaks, you're GBS negative, there's no need to start PIT. A period of time can be given where we can give the mom time to go into more active labor on her own. However, they do also say that if GBS positive, group B strep positive, do not delay antibiotics until labor starts. So they're saying we give antibiotics for that during labor. It needs to be started. We don't need to be waiting for those regular contractions of labor to start to give it. Okay, number 5. In addition to nursing care, one-to-one support is recommended, which has been shown to improve outcomes. So basically it's saying that women who are supported are successful, and it statistically increases their outcomes. So mamas need support from their family or a doula or a labor nurse. Sometimes it's hard for the nurses to give one-to-one care in some facilities depending on their patient ratio, but regardless of who it is, women need that support. They're going to be successful. Number 6, routine amniotomy. So that would be artificially breaking the water versus it's breaking on its own. So the doctor takes a hook up inside the woman's vagina and ruptures that or breaks that bag of water. So routine amniotomy need not be performed in a normally progressing labor unless fetal distress requires a monitor to be placed on the skin of the baby's head. So they're saying if they're having trouble monitoring, if there's an issue with baby, they have a little, it's like a safety pin type needle that screws underneath, just superficially under the skin of baby's head, and that's an internal monitor. Sometimes you'll hear it termed. So they're saying if baby's not in distress and we don't need better monitoring like that, there's no need to routinely break the water versus letting it break on its own. Okay, number 7, to facilitate intermittent monitoring, staff should be trained to use Dopplers and utilize intermittent monitoring for low-risk women. So it's basically saying train your staff so they know how to do this, so it's an option for women who are low risk. Number 8, a coping pain scale. So if you've ever been in the hospital, they'll say, hey, rate your pain on a scale of 0 to 10. How bad is it? So it's saying using that scale, in conjunction with non-pharmacologic and pharmacologic methods should be used to help tailor to the individual care goals of women. So basically, using all of these combined depending on the woman's goal of pain relief. So like I said, that is that thing where you don't use your own bias to treat your patients. So this means that we're going to tailor the care individual to you guys. If you want an epidural, we're going to help educate you about when and how to get that. Or if you don't want it, we're going to guide you through that. That's what it's saying, is use these in combination to help women be successful and have good outcomes. Okay, number 9, frequent position changes. So this is versus lithotomy or on your back in bed. So lithotomy is on your back with the legs up in the strip. So what they're saying is frequent position changes, not laying on your back throughout your whole labor, whether you have an epidural or you don't. Those frequent position changes should be utilized to facilitate not only labor comfort, but also optimal fetal position. So baby can actually be in a position in which it prolongs the labor and pushing. So a lot of times this is called posterior, sunny side up. The baby's head is not rotated down the way we want it to. Still can come out that way, but it's a lot more difficult, and it creates a longer labor oftentimes, especially in a first-time mom, and longer pushing. So what it's saying is these position changes not only help with labor comfort, but it's going to help prevent that position from happening. So we are setting moms up for success versus being in one position, sometimes with an epidural, sometimes not changing position, and so we're going to prevent that baby going into that position. Okay, number 10, almost done. Number 10, women should be encouraged to breathe how they choose during pushing in whatever way is most effective for them. So this is saying that it doesn't have to be that eye vessel busting, red-faced, puffed cheeks, counting to 10 kind of pushing, which often promotes exhaustion. It's also saying that it needs to be individualized. So if a woman has an epidural, can't feel the urge to push, we may need to coach them a little bit through breathing, but essentially it's saying women should be able to breathe how they want, not holding their breath for the count of 10 just because that's the way we've always done it. Some women will push what is called open glottis, which is less of a and more of a letting noises come out, deep throaty voices, they say, help open up areas that help baby come down. So it's saying that women should be encouraged to breathe however is most successful for them. They don't have to hold their breath. Number 11, women with epidurals should be given an option to rest for 1 to 2 hours before pushing if they don't feel the urge to push due to the epidural once 10 centimeters is reached. So usually when you get to 10 centimeters, you start pushing, if you don't know that. And with an epidural, sometimes you don't feel that urge to push, and you are 10 centimeters, and baby's head is still very high, which is going to require a lot more work through pushing. So this is saying that there is no reason that women can't rest for 1 to 2 hours before pushing if they don't feel that urge to push or that pressure. And what this is going to do, so sometimes it's hard to push with that epidural if you don't feel that urge to push baby out. So this way, resting 1 to 2 hours, baby can work its way down with those contractions instead of exhausting the mom and pushing with little to no progress for hours. It's often termed as drifting or laboring down is what we call it in the hospital. So that's the last one. So these are the recommendations, the evidence-based recommendations, and I hope they made sense to you. I am happy to provide anybody with access to this recommendation, the article, should you be curious to read it for yourself, which I hope that you are curious to read it for yourself because it's important to stay informed and not trust me or anybody else for your own information. And also, I would love to direct you to the evidence behind these recommendations as well as any other information that you may have questions about, because I'm all about the evidence, girls. I am going to leave you with this. So your doctor's appointments are not long enough to give you all of the information. And unfortunately, sometimes providers, not always, but sometimes they aren't always practicing with the most up-to-date practices. So you have to stay informed, mamas. I always say research, pray, choose. Whatever you may be deciding, research, pray, choose. And always stay informed. Thanks for listening, guys. I hope it was helpful. Bye.